So Peter, I can see we are on time, and we are having attendees coming in.
Yeah, we're having attendees coming in. 5 minutes for them to join. Yeah, I'll have you take over.
We give them 5 minutes. Okay.
Yeah, 5 minutes, 3 to most. Yeah, you can see
Thank
the
you.
numbers are rising very fast, sir. Okay.
Yes. I think Peter, you can start off.
Yeah, go on, Dr. Welcome.
Good afternoon, ladies and gentlemen. I would like to invite you to today's one of our most interesting topic that we've been having for quite some time. It's a series of discussions that we've been having for quite a long time. We're going to look at the current MOH COVID-19 response measures, and we'll go around implementation and the impact and its interpretation from us and from MOH. And today we are privileged to be moderated by myself. My name is Dr. Okinyi David, Vice Chair of KMA Kisii Division, and also working in Kisii County in the Department of Non-Communicable Diseases, heading it. And I'd like to, at this point, before I bring to us our presenter, I don't know, I'll request our president, the KMA president, Dr. Wero Nyino, to just greet us before we go straight ahead as I present to you our guest today. I don't know, President, you are around?
Thank you, Philip. I'm here. Thank you, Dr. Marybeth, for agreeing to come and share with us your insights about the current MOH COVID-19 measures. Of course, we've been getting a lot of questions from the healthcare fraternity on what the new measures mean in terms of the COVID-19 pandemic, how we are going to ensure that we contain and remain safe as healthcare workers. So I think today is a very important topic that you're going to share with us, and we are eager to listen and learn from you so that we can continue be on standby, especially seeing from the data that is still coming in from countries like UK, like China, the new variant that is there. And what does that mean for us going into the future in terms of the COVID-19 containment? So I thank you so much for taking this time, and maybe I might ask the head of our COVID-19 clerk committee, who is my vice president, Dr. Otara, maybe to say a word and officially welcome you through the moderator to give your talk. Asante sana. Back to you.
Is the Vice President on board?
Yes.
Yes, Dr. Rikam. Yes,
Good afternoon,
Karibu.
everybody.
Good afternoon.
And I'm here as a member of the COVID Response Advisory Committee at the Kenya Medical Association. And this is really a timely presentation. I really look forward to a good presentation from Marybeth, who has been very instrumental in advising us on the trends of COVID-19 in the past 1.5 or 2 years. And as the president has said, there are a lot of things that are out here in the public. It's too early for us to drop the guard. And what are the lessons learned, and what are we intending to do subsequently? So just welcome all the members, and looking forward for a very enlightening discussion. Thank you so much.
Thank you very much. Today, this afternoon, we are privileged to have one of our own, one who has been passionate around this pandemic time to discuss so much about this COVID-19. She is so much interested in infectious diseases, a lecturer in the University of Nairobi, Department of Internal Medicine and Therapeutics. And she's a physician, one and only Dr. Marybeth Maritim. I don't want to say much about her, but at this point in time, I'd like to welcome all of us, Karibu Sana, so that we can take a look into this discussion. Please, what I'll request is we write down on the chat box, or I'll give a few to shoot their questions, so that after her presentation, we'll have Q&A session before we'll pick a few for her to discuss. Then we will see what next. Karibu sana, Daktari, take over. Thank you.
Thank you so much, Dr. Akinyi. Thank you, President, and I think it's Vice President, not Deputy President, for KMA for this invitation to give the talk this afternoon. So I hope you can hear me.
Yes, you're loud and clear.
Okay, so I'm hotspotting my computer, and I think if my internet becomes unstable, just warn me so that I can be able to troubleshoot. So today I'm going to be talking about the current Ministry of Health COVID-19 measures. And I think the initial topic that was suggested was alluding to that we have gone back to pre-COVID times, but I modified the title just to help us focus on the current measures, what they mean, how we interpret them, how they are being implemented, and the likely impact of these measures. So this discussion is not really a lot of science, but it's more discussion generating, so that we can put our heads together to see what we need to do at our individual level, at the county level, to be able to detect a surge or an increase in the number of cases, because that will then necessitate an increase or a resumption of the original measure. So this current reduction in the measures, I think, is very different from previous one, because in the past we've had very severe measures, but now they are very relaxed, and many of us, me included, have been anxious about the impact of that. So this is very timely. This is the outline of my presentation. It's not a very long presentation, but we'll go through a brief introduction looking at the local data that really helped to inform the current directives, and then look at what are those current measures that are recommended, and how are they being interpreted either by us or other people. And we know there are many gaps in the interpretation and even how they are being implemented. And then also reflect on the likely impact. It's very difficult to say the impact until you start seeing the trend where we are headed. So impact normally occurs, like you can look at impact in a retrospective manner rather than in a prospective manner. But in this presentation, I've tried to see what are the likely things that can happen because we've lifted some of the restrictions. And then what do we need to do at individual facility and even at the national level, and then just conclude. So I know many of us have resumed our day-to-day jobs and therefore are not keeping tabs of what is happening in the COVID world. So every day the Ministry of Health sends what is called a situation report. And this is from the situation report of yesterday, which showed cumulatively we have a total of 323,000 cases that have been diagnosed through testing. We've had 5,647 deaths. And then we have a proportion of adults who are fully vaccinated, amounting to close to 8 million adults. And remember, we had a target of close to 26 million adults to be fully vaccinated. So we haven't still achieved that target. I put this graph just to put us into perspective. This is again from the situation report that's shared daily. And basically it shows us the different waves that we've gone through. We have just come out of the 5th wave, which was mainly characterized by the Omicron variant that was between December, declining in January. And you can see that from that last wave, the wave was very acute. So it had a very high peak and it was very short. And the reason why this wave was very short is around October, actually October, November, the cases declined and there were easing of restrictions. And then all of a sudden there was an outbreak of a new variant in South Africa. So before any restrictions could be instituted, the wave arrived and circulated and many people got sick, including even people who got vaccinated. And this explains why this wave was very quick. It quickly happened and the cases reached very high numbers. And basically it started declining up to where we are now. So we have just finished the 5th wave, but you can clearly see all the other waves. The first wave early in the pandemic, last year, July. Then we had another wave around October, November. Then we had the wave early last year, March, April. It did not really decline so much. And then we had another wave in July. So it's like the two waves were intertwined together. But the cases went down until a new variant was introduced in the form of Omicron. So we can clearly see the waves. And this is really very useful because when we have this surveillance system, it enables us to identify when the cases are rising. And clearly we can see currently the cases are very down because when the cases are rising, it's difficult to hide cases. I know many people don't go for testing, and particularly for Omicron, many people did not go for testing, including even healthcare workers. They did not present for testing. But when there are cases and there are admissions, and in this graph, the blue figures at the top of each graph is really the symptomatic cases that present to hospital. And this again contribute the proportion of patients who result in mortality. So it's very difficult to hide admissions. It's very difficult to hide mortality. So even though we may have a large proportion of people who are mildly symptomatic or asymptomatic in the community. We still have systems or early warning systems that enable us to detect cases in hospitals. And therefore, we can be able to see a surge in cases, even though people may be in the community, but the hospitals will start receiving patients, and the numbers in the hospitals will start increasing. And currently, we don't have many patients in the hospital. The positivity rate has declined to less than 5%. So we don't have the curves that we've had in the past. To keep this in perspective, and really to even explain that the current measures that were announced were really related to this data. This data helped to inform some of those decisions. This is another graph that complements the graph that I've just shown you below previously. And this is the graph of corresponding COVID-19 deaths. And we can see every time we have a wave, a surge in cases, we have a concomitant rise in number of mortality. So we've had 1, 2, 3, 4, third and fourth were merged together. So we've had 5 waves of infection, and we can see corresponding 5 waves of mortality and increasing mortality as we go along. So every time you have increasing number of cases, the hospitals are likely to get overwhelmed. And basically it reflects on a large community outbreak. And therefore the people who present in the hospital are likely to be the ones who we've described in previous webinars, would have risk factors for severe illness and would present in hospital, and a proportion of them would lose their lives. So we are currently looking at data to see of these patients we've lost in the recent past, what proportion of them had received the vaccination and what proportion had not received the vaccination, because vaccines have been shown to reduce mortality and even severe infections resulting in admission. So we want to see what proportion, and chances are many of these people who presented to hospital and lost their lives had not been vaccinated, despite the fact that we have so many vaccines in this country at this point in time. So this is the data around the number of doses of vaccines that have been dispensed. And this data is up to 22nd of March. And we can see different groups. So we have adults who are partially vaccinated, who have received 1 dose over 2 dose schedule. Those are close to slightly over 2.5 million. The fully vaccinated adults are close to 8 million. We only have a small proportion of people who have gone to receive their booster. So for you to receive your booster, you must have completed the primary series, which comprises of 2 vaccine doses with an interval in between. So we can see the uptake of the booster doses is very, very low. And boosters are recommended for certain groups of patients, particularly those patients who have comorbidities and even healthcare workers, because your booster boosts your immunity. Current evidence seems to suggest that durability of protection, the antibody response starts to decline after about 8 months. So it may not decline back to like baseline, but you want to maintain a level of immune system that's protective. So we are all encouraged to go for our booster doses so that we can have ongoing protection. We also introduced vaccination for children aged 15 to 18 years, because we already had evidence globally that this group can be vaccinated safely with the mRNA vaccines. And so far we've vaccinated just slightly over 1 million of young adults aged 15 to 18 years. The fully vaccinated young adults are under 200,000. So the proportion of fully vaccinated adults is 29.3%. So remember, we are targeting 26 million and only we fully vaccinated close to 8 million. So we still have a long way to go to achieve the vaccination. And really, the easing up of the measures is informed by a number of things. One of them being the vaccination coverage, because vaccination provides protection. Another thing that informs easing of the measures would be the proportion of people who are infected. So the community infection, because even following natural infection, there's development of immunity. So looking at the statistics, it's estimated that a large proportion of people have already been exposed to SARS-CoV-2, either through natural infection or having received the vaccination. And therefore, we have a high level of circulating immunity in the community, and that would provide herd immunity and reduce the risk of infection. But again, one of the things we know is that the immunity doesn't last forever, and therefore we need to look at, particularly if there's an introduction of a new variant or a new, mainly a new variant that we haven't been exposed to before, then it can contribute to an increase in cases, particularly if there's declining immunity from both the infection and from the vaccine. So again, this is a map showing the distribution of the vaccine coverage, and we can see some counties are doing very well, but we have the far-flung counties like the arid counties of Marsabit, Wajir, Isiolo, Garissa, Tana River, Kilifi, Kwale, West Pokot. Basically, the arid and semi-arid counties seem underrepresented in terms of vaccine coverage. And this may be related to logistics, access, and basically education of the communities to improve the uptake of the vaccine through demand creation. So I think we still need to do a lot to be able to get the vaccine to be acceptable in certain parts of this country where the coverage is very low. And we can see from some of the counties is as low as 9.6, just hovering close to between around 10 and 15%. So we need to do more. And normally it's very difficult to convince people to take the vaccine when they can't see the disease, particularly now when we've said we've eased up a lot of the measures. People assume that the disease has been kicked out of Kenya, and therefore even the uptake of vaccine is likely to remain static at this point in time. And even from the data that I have had a chance to look at, most often the uptake of vaccine was driven by a surge in cases, and that's when many people presented to facilities to actually receive their vaccine. So at this point, when we are not seeing a lot of cases, it may be difficult to get the vaccine numbers higher than they are already. So having said that, and speaking to what was mentioned before we had the discussion, there's been a new variant that's been described in Southeast Asia, and it's called BA2. It's a subvariant of Omicron, and it's currently circulating in Hong Kong, China, and other parts of the Southeast Asia. And we really need to be careful, because if it is introduced and it starts circulating, then it will find us in a situation where we may have another outbreak and a surge in cases. So the most important thing is really active surveillance to be able to trace, so that when we notice that the cases are starting to go up, then we put in place the measures to be able to curtail and prevent a dramatic surge in cases, which then can lead to overwhelming of the healthcare system. So coming back to the current measures that were announced on 11th of March and summarized as social distancing. So in social distancing, this is sort of, there's a soft recommendation about social distancing, because in the directives, we clearly see that facilities and churches can hold gatherings with full capacity. So that again means that there is hardly any social distancing. When it comes to hand hygiene, the directive is fairly soft, because it's encouraging Kenyans to ensure frequent hand washing with soap and water, using hand sanitizers at all times. And therefore it's relying on persuasion and convincing people to do the hand hygiene. And I think the wording should have been more stringent to sort of say hand hygiene should continue. So when you use encouragement and persuasion, it leaves it very difficult to interpret. And we've clearly seen this in many of the social facilities that we go to. Many shopping malls now, you'll struggle to get hand sanitizer. The same thing with ATM machines. When you go to withdraw some little money from the machine, you'll really struggle how to get the hand sanitizer, because most hand sanitizer dispensing machines now are dry. A lot of the times when the watchmen were having the thermal guns and were taking temperature, then they had the sanitizer on the other hand. And because we've said the thermogans are no longer there, then we don't have hand hygiene. So you find that you may want to wash your hands in a public place or sanitize your hands when you're going to a public place or after you've been in a public place. But we have lost these opportunities because these are not provided. And I think it's in the wording of the directive, because we were encouraged. So it basically means that as individuals, you have to carry your own hand sanitizer. You have to remember to sanitize as frequently as possible. So that is a major, major loss, because as we shall see in a subsequent slide, the hand hygiene has benefits beyond even COVID-19. And those diseases that were prevented by hand hygiene are surely gonna make a comeback in the coming few weeks. Now, coming to the issue of wearing of face masks, the directive says the mandatory wearing of face masks in open spaces is now lifted. Nonetheless, people are encouraged to maintain social distancing and avoid crowding even in public places to ensure risk of spread is limited. We are, however, encourage the use of masks in all indoor functions. So looking at the word that is used there again, encourage the use of masks in all indoor functions. And I know many people have even attended some functions and we are not motivated enough to wear the face mask, because in the directive, it was just encouraging us. It wasn't forcing us to wear the face mask. So that presents an implementation challenge. I think the only place that I've seen consistent wearing of face masks, and this is to be commended, is healthcare workers. Healthcare workers in clinical spaces, in the ward rounds, and even medical students, healthcare students are still wearing their face masks in the clinical areas. And this is really to be commended and to be continued, because we are really at that interface where we can be predisposed. So we really need to protect ourselves. And we know that patients can present for other conditions and may be asymptomatic. Even the ones who have variants may be carrying the variants and may not have the symptoms. So we need to continue wearing our face masks in our clinical areas, despite the wording saying us being encouraged. So we should wear our face masks in our clinical areas. With regard to vaccination, vaccination is the other thing that is really emphasized. It's emphasized in the resumption of gatherings, particularly in religious places. It's also emphasized in terms of gatherings for sporting activities where spectators should have been vaccinated. So again, it's emphasized there. And then when you look at screening at the ports of entry, people who have received full vaccination are exempt from certain potentially punitive restrictions. So when people are fully vaccinated, they are allowed to come into the country without necessarily doing the COVID PCR test. So they don't have to do a COVID PCR test if they are fully vaccinated. But if they are unvaccinated, then they have to do the COVID test, and they would also, if they test positive, then they would have to quarantine at their own cost. So that is a punitive measure that's supposed to promote vaccination, but I'm not sure to what extent it would be successful in encouraging vaccination. So again, speaking to the vaccination and attendance of indoor functions at full capacity, particularly in the churches, I don't know who is inspecting the COVID vaccine certificate to allow people who are vaccinated. So that presents an implementation challenge, because you're saying there's a precondition to doing something else, to full gathering or forfeiting social distancing. But who is tasked with ensuring the vaccination? Again, it's not very clear in the current measures, and therefore that presents a challenge with regard to implementation. When you look at, again, conveyance system or public transport, we know that public transport systems, including vehicles, trains, and domestic air flights, they are actually carrying passengers in full capacity. So the staff in the directive, it recommends that the staff are fully vaccinated, but then what about the travelers? It's not that the COVID will be only in the staff who are working in those facilities, but even the travelers can should have been required to, or should be vaccinated to minimize the risk of transmission. And then the issue of implementing even face masks during the time in the course of travel. I'm not sure that in the public transport vehicles like the matatus, this is really being fully implemented. So that presents a challenge because you have this lack of social distancing, there's crowding, there are people spending sometimes, if you're going on a long trip, like for example, from Nairobi to Western Kenya, where you take about maybe 6 to 8 hours, and if you're not wearing your mask, then that's a long distance indoor setting. And if you're not fully vaccinated, then that puts you at risk. But I think the only consolation with regard to all that is that our case numbers are very low at this point in time. And therefore, even coming into contact with someone who may be infected is a bit low, particularly because the case load is low. But should there be an introduction of, for example, the new variant, the BA2 variant, then it would be difficult to see that transmission is not occurring in such transport systems where we have sort of like removed all the measures that were protective. So we've already talked about the screening at the ports, and this is important, particularly for surveillance and likely introduction of a new variant, because these variants have not been described in our part of the world. And most often when you have a new variant, the next phase is a surge in cases. So it's very difficult that you could be having the new variant here and our cases are going down. So the hypothesis is that the new variant is going to come from elsewhere, and therefore the screening at the ports of entry needs to be enhanced to be able to pick up potentially points where this can be introduced. So again, the current measures need to be robust enough to detect and be able to put in place systems to prevent or minimize the numbers of introductions, because often the number of cases that are introduced then can determine the magnitude and the peak of cases and overwhelming of healthcare system. So having talked about the measures in summary, interpretation and implementation of these measures, we know, and I've already talked about this, that face masks are not being worn in a lot of indoor venues because people are not motivated to wear. So there's a general sense that COVID is now finished. Many of us even have talked, and we are talking about COVID in the past. We talk about like the pandemic is finished. Maybe we are in the last phases of the pandemic, but as of now, we can't really say the pandemic is finished, because for it to be finished, it cannot only be finished in Kenya. It needs to be finished in all parts. And we know that it's been circulating in the Northern Hemisphere, which may be explained by the weather, the current winter weather. But July is not too far from now. And we know we are going into an election period. So we may be just through a phase where our cases are down, but the cases might start to trend upwards shortly or soon. So the face masks in an indoor venue has been difficult to implement or enforce. And then hand hygiene, we know that hand hygiene, like I've explained, again, is not provided in many places. It has to be now an individual to have their sanitizer to be able to perform the hand hygiene. And therefore, it actually denies a lot of people who are willing to perform the hand hygiene that opportunity. And we need to see how to encourage, either through education, messaging, working with CSO organization to just provide hand hygiene stations in many places in a sustainable manner. And that social distancing, again, this has been left at the discretion of for interpretation by whoever is trying to interpret the directive. And it's been in the COVID-19 measures and the announcement, it was left at the discretion of really the organizers of whatever events there are, or even the church and the I think it's called Interfaith Council around the protocols for resumption of full capacity worship in church and other religious venues. So again, and that is linked to what I was talking about, the verification of vaccination status. So it becomes very, very difficult to implement successfully because one requires the other. And then we've already talked about the challenges with incoming passengers and the fact that we are not actively screening. We are only screening people who are not fully vaccinated. So again, interpretation, implementation presents a lot of challenges. So what have been the benefits of these public health measures, even beyond COVID-19? We have seen a reduction in respiratory droplet infection significantly. This includes things like influenza and other infections, not necessarily respiratory, that can be spread through droplet, things like meningococcal and other respiratory pathogens like strep pneumo. So again, this has been a benefit of wearing the face mask. And that's why for us, even who work in the healthcare space, we want to derive this benefit so we don't abandon our face masks. For people who have a history of allergy and dust and frequent colds because of dust and other things that are in the environment, many of them have actually reported a reduction in their episodes of allergic events or even exacerbations of bronchospasms. This has not been quantified in a study, and I think this would be a worthwhile study to find out, because many of people I've interacted with, they actually want to continue their masks because they say they derive a lot of benefit since they started wearing the mask. They don't have any homa, they've not had attacks. So this is something that would be done and would encourage them to continue wearing their face masks. And this is particularly useful, like in countries like China, where there are very high levels of air pollution. Many people wear their masks to protect them against the air pollution, and therefore they derive the benefits of protecting the respiratory tract. The only caveat and the potential risk maybe with regard to face masks has been the disposal of the face mask, because many of them are not necessarily biodegradable and they present a risk of environmental pollution, which maybe is the biggest risk. So if you're to weigh risk and benefit, and maybe this partly went to inform the directive in terms of reduction of wearing of face masks in open places, because when the cases are down, the protection accrued for preventing COVID, I think the environmental pollution risk outweighs that the benefit now in terms of COVID-19 because of the magnitude and the amount of masks that have been worn since the onset of the pandemic. When you look at hand hygiene, again, most of the benefits are actually shared between the three interventions. So face masks, hand hygiene, and social distancing reduce respiratory droplet infections because they spread within a certain distance, they're spread by hands, contaminated hands, and therefore the hand hygiene gives that benefit of reduction in respiratory droplet infection, things like influenza. And then there has been a reduction in diarrheal diseases, things like cholera. I know many of you before the pandemic, we had a lot of outbreaks. Remember, even healthcare workers, there was an outbreak somewhere in one of the hotels during a conference. And then after that, we had a lot of outbreaks in different counties. But since COVID-19 came along and people are doing hand hygiene, we actually have not reported outbreaks of cholera in a very long time. So that has been one of the benefits. So cholera is a typical diarrheal disease, and there are many other diarrheal diseases and other diseases that are spread through fecal-oral transmission because you require the contaminated hands that then contaminate the food and other pathways, which then people pick the infection. So things like hepatitis A outbreaks, cholera infections, and other diseases that are transmitted through fecal-oral transmission have actually reduced significantly because of the hand hygiene. And therefore, the opposite is likely to happen because now hand hygiene has been thrown out. It means we will start seeing a resurgence of these diseases, and we have a very good surveillance system, the national surveillance system, that is able to track. And I know in the coming months, if the current measures continue and we don't reintroduce them because of COVID-19, then we are likely to start reporting some of these diseases. And then the social distancing, I've already spoken about that. So this is from the disease surveillance system. It's the EP report for March 16. Every so often, they share this report to compile outbreaks of diseases that are ongoing in the country. And basically, to summarize, I know it's very small print. I will not want you to focus on the fine detail, but the first disease that's described, highlight 1 is COVID-19 pandemic. Highlight 2 is visceral leishmaniasis outbreak. Highlight 3 is chikungunya outbreak in Wajir County. The visceral leishmaniasis outbreak has been in 8 counties: Marsabit, Garissa, Kitui, Baringo, West Pokot. The drier counties, Mandera, Wajir, and Tharaka Nithi, because you cannot read the small print. I'm just reading for you. And then chikungunya in Wajir, mainly. We have a dengue outbreak in Mombasa and Mandera. And then the recent yellow fever outbreak that was announced, mainly in Isiolo sub-county, but other neighboring counties are at risk. And basically what we can see, and why I put this report specifically, is because all these diseases now where we are reporting outbreak are vector-borne diseases. Where visceral leishmaniasis, we have the sandfly vector, chikungunya is a mosquito, dengue and yellow fever, they share the same vector, which is the mosquito, specifically the Aedes aegypti mosquito. So we can see from the outbreak situation in the country, and this has been more or less the same since the COVID-19 outbreak. We don't have diarrheal diseases, we don't have cholera outbreaks, and we are watching the space to see the impact of lifting the restriction. All these are related to vectors, and sometimes the interventions we've talked about, face mask, hand hygiene, social distancing, can't really protect you from a vector. You have to break the cycle of biting by the vector. So again, just evidence showing that the interventions had worked to prevent the diarrheal diseases. So what are the likely impact of these removals, the current phase that we're going through? There is an apparent perception that there is no risk of COVID-19. Actually, when you talk to the local person, mwananchi, people think that COVID is finished. People talk of COVID-19 in the past, like it's not there anymore. So there's that reduction of risk, and therefore even people are likely to now engage in riskier behaviors, which if there's a variant that's introduced, will find us at a disadvantage. There's likely non-adherence to those directives where there's persuasion, like encouragement to wear a face mask, especially in indoor places. Then you find that people are not likely to adhere to that. So there's likely non-adherence to even the guidance. And then non-provision of hand hygiene station in many public places has already been noted, and it denies many people an opportunity. And therefore, we stand the risk of those diseases that the other benefits that we had accrued are likely to start, we are losing those benefits. So we'll start having upsurges of diarrheal diseases. So the risk of other infections like cholera, which is transmitted, it's a diarrheal disease, fecal-oral. And then we have influenza, which is again a respiratory droplet infection. And then we stand a chance of COVID-19 cases trending upwards, and perhaps a new wave of infections, particularly if there's introduction of a new, more virulent variant. So we really need to have a robust surveillance system to enable us to detect the few number of cases, because then that will act as an early warning system to enable us put in place some of the restrictions that have worked for us in the past. The other thing is the issue around the economic. So when COVID-19 came, it really changed our lifestyle. We had to adapt, and therefore some of the gains that we have benefited from, we are already starting to lose them, and therefore we need to see how to secure so that we don't entirely lose. So case in point is with the reduction or lifting of wearing of face masks in public places, there will be a reduced demand for face masks and even hand sanitizers, because they're not being provided in public places. So it's only people who are highly motivated who will go and buy the hand sanitizers. And the result of this is that it will actually lead to reduced supply. And we know that some factories are actually dedicated their factories to production and having the face masks and sanitizer production. So when we lose this capacity through reduced production, then we stand at risk of prices going up. Basically, the things that we faced at the beginning of the pandemic, we were buying face masks, a box of face masks for about 5,000 shillings. the face mask, the same quality of face mask that we bought for 5,000 shillings was currently selling at around 250 shillings. But if you have reduced production, reduced demand, there's likely going to be a situation where we'll be struggling even where to buy the face mask. So for healthcare workers, please stock up on your face masks, because when the need arises, you'll still need your face masks, and they may be difficult to get, and the prices are likely to now go up. You can imagine if a factory was repurposed to produce face masks, maybe by this month already they are thinking of what else they can start making. So there'll be reduced supply, and this will push prices upwards. The other thing is there's likely to be a challenge with upscaling some of this capacity that we had built when the need arises, and therefore we need buffer stocks of things like face masks, hand sanitizers, commodities for testing, viral transport media, because if we lose all this capacity, then when there's an outbreak, then we'll not even be able to cope. So we need to have a buffer supply to enable us to cope when the cases start going upwards, until we are certain that the pandemic is really behind us. Again, there's likely to be reduced testing, and therefore even the people who are trained in the labs to do the testing are likely to be redeployed to other places if they have not already been redeployed. So they are likely to lose their proficiency, they're likely to lose their acumen, and we need to have a way of maintaining that capacity so that we don't lose that capacity. Because if we lose the capacity, it will be very difficult to regain it when that time comes around for us to require that. There's likely to be reduced investment in surveillance, and this may miss introduction and early surge of cases. So this, I'm talking about surveillance at county level, surveillance at national level, surveillance at ports of entry. And the importance of this is that in the directive, quarantine was one of the things that was spoken about, that there's no need to do quarantine and even contact tracing. So it means like that we have really put everything on our stop, but we really need to have that capacity. And the people who are trained should have that capacity so that when we need to put in place the systems, we're not going through a phase where you have to retrain everybody and set up systems entirely, because that's very, very costly. So we need to have some baseline capacity that is maintained somehow in the counties, and I hope the counties are keeping note of this, so that even when you need to do things like quarantine, surveillance, contact tracing, when that need arises, we have some sort of capacity, and we're not restarting again from the beginning, because it will be very, very costly, and I don't think we'll have those resources to reinstitute everything that we already had been through. So what we need to do, this is now approaching the end of my presentation. So basically, there are certain things that we need to do at individual level, at facility and county level, and at national level. And my list is not entirely exhaustive, but it's really just to provide a perspective. So we need to maintain the risk awareness individually, among ourselves, even within the patients, even within our families, so that people, even when they're entering a public transport system where the directive encourages us to wear a face mask, just always be aware that your neighbor could actually be having COVID-19 and can pass the transmission. So the motivation to wear the face mask, the motivation to perform hand hygiene, the motivation to even adhere to some of the things that can protect you in that transport system are driven by yourself as an individual. So having that perception of risk and thinking that your risk is still there, although at a minimum, we need to maintain that. And particularly for us who are in the healthcare occupation, our occupational risk is ongoing, and we need to wear our face masks in the clinical areas. And I'm very motivated because I know even when I visited our facility in Makueni today to do a CME, we were wearing our face masks in that facility. So again, being aware and wearing face masks, because clinical areas are opportunities where you can pick other infections, not only COVID-19, and particularly droplet infections. And therefore, wearing the face mask, we derive more benefit from wearing our face masks, and we need to continue that. We also need to continue hand hygiene practices in our clinical areas, not only for COVID-19, but we know that hand hygiene is a very, very important measure for infection prevention. and control, and it limits transmission of infections across patients. Actually, our hands are the ones that carry resistant bacteria from one patient to another. So performing hand hygiene in our own clinical areas and even in public places is really, really important. I've really emphasized for the clinical areas because I know many of us are healthcare workers listening in on this webinar. And then we need to continue social distancing where possible. I emphasize in the clinical areas, but where possible, even in our own personal spaces. And then at facility level and county level, I really urge us to retain some residual capacity, which can be scaled at short notice. This will include testing capacity where you have the antigen test. The people who are already trained to do the rapid antigen test, they need to be, like, we need to keep an inventory of the people who are trained and where they are. Even when they are redeployed to other places, we need to have a list of those people who have developed capacity and training, so that if we need to mobilize a team, we are not starting from scratch. I know facilities have very high turnovers, particularly for people maybe going to train, further studies and things like that. I know even some people have gone into politics, so they are leaving their stations and going into a new capacity, maybe as political aspirants. But if we can keep an inventory, so that if we need to say we are reopening our isolation units, then we are calling the people who already had been trained, like the IPC team, the clinical team that are already trained, so that it's easier to mobilize that team of people at a very short notice. At a national level, I think the important thing is to maintain an ongoing testing and surveillance system. And this would include genomic surveillance to allow for detection of variants. And this genomic could really include at the points of entry. So if you have the travelers who maybe are not vaccinated and need to come in and they have symptoms and samples are collected, we need to subject those samples to genomic surveillance to be able to identify when a new variant is being introduced. Because when a new variant is introduced, within a short time, it's the variant that really takes over and now becomes a dominant variant. We need to maintain our early warning signs to detect the threshold to guide reinstitution of the public health measures. And our group is doing this because we also monitor cases within hospitals. So if we see that the cases in hospitals are starting to go up, then that will be a trigger system to say maybe we need to reinstitute some of the measures. And when you're instituting the public health measures, I've called them here public health measures, but they are broad measures. And this, we already went through these phases of measures at the early onset of the pandemic, things around restriction of movement, strict isolation and things like that. So it's not only the face mask, hand hygiene, and social distancing, but even things around quarantine, contact tracing, where necessary, may need to be reinstituted. So that's the end of my presentation. Thank you very much. Like I said at the beginning, it wasn't really a lot of science, but it was more like reflecting on public health issues and what we need to do to enable us put our heads together to come up with solutions. So I'll stop there. And if there are questions in the chat, then we'll move on to the Q&A. Thank you very much. Back to you, Dr. Okinye.
Thank you, Daktari. Thank you, Daktari, for the wonderful presentation. And I'd like to say that this has been a very eye-opening reminder, and also to sustain what we've been doing to enable us to come to the end of this pandemic. As you've seen, the five waves, especially on the deaths, the fifth wave has been remarkably reduced, and this, my assumption will be the good work that we've done with the vaccination, though it has not come to our herd immunity. 29.3% is not so good, but it's better than what we had started with. I'll go straight ahead to the questions. I'm saying so far we've had, I'm seeing 5 Q&A at the Q&A chat box, and there are some 3 at the normal chat box. So I'll just start with what Dr. Jen Karaoke has asked at the Q&A session. I'll just take the 5. I hope, Dr. you'll pick the 5, then we go to the normal chat box, we see what's there. Dr. has asked, thanks for this update. We are having a huge challenge asking patients and relatives to wear masks, especially at the private clinics. And the patients usually say that the government has said this is voluntary. And she's asking, how do we tackle this? She feels that it should be a directive to not to encourage not to wear masks. The second question is about the Data Privacy Act. When patients are usually asked to present their certificate at the security checks, they usually state it's private and confidential data. How can this be resolved? Then there's another question from Gingo. What are some of the scientific indicators that can be used to announce at the end of the pandemic? Then Abdirahman has mentioned something about what is the interval of booster dose and second dose. Probably, Dr. you can pick the first four, then we can go to the next three remaining. I hope you got them. The first one about the challenge of private clinics and the wearing of masks, and the certificates. You can take it up.
Yeah, so thank you, Dr. Jane, for the questions, and they're very pertinent, and I even struggle with them because of the wording of the directives. And the directives are persuasive. It's like they are, like it's anyone's interpretation of what they really mean, and therefore it puts it at the interpretation of whoever has the upper hand. So in this case, for example, the patients who are motivated would probably adhere, and the others would not adhere. So I think the only way to overcome this is, for example, in your clinic, insisting that people wear the mask so that it's not optional. If people don't want to wear the mask, then you can tell them they cannot come into your clinic without wearing the mask. And I'm just hoping we'll have an opportunity where maybe one of these days they can be reannounced, and really should not be using the persuasive language or encouragement, so that it's actually listing the specific areas where people must wear a mask and using the word should or must. So I totally agree with you. It's very difficult to implement as it is now, because it's not a firm directive. It's sort of like relying on the patient's volition to wear, and they can opt out not to wear. Yet the clinic is an indoor place, and the directive says in indoor places people are encouraged. So it maybe would require a negotiation, so that maybe when they are reannounced, the words that are used actually clearly spell out that in certain places I don't know what to call it, but sometimes you read legal language where it's like the owner, the discretion is at someone else has the discretion to demand something else of someone else. So that way, if it's in your clinic, you can have that discretion to say that if you're not masked, you can't come to the clinic, so that to give people a sort of like an iron fist to implement the face mask, particularly in certain spaces. The same thing, again, you've alluded to in terms of how people are able to escape demands to show their vaccination certificate. Because when they say it's private and confidential, and the askari is just there, the poor watchman, there's nothing much really that they can do, because the certificate would either be on a phone or somewhere on a device, maybe, or even printed. So it's just they're taking advantage of the poor watchman, because when the airlines demand that you show vaccination, many people cannot escape that. But because it's just a poor person who most often, the person who would be saying about the Privacy Act and data, maybe are on a position of more power than the poor askari. So therefore, it becomes very difficult to enforce. And I alluded to this in my presentation when I was talking about even within the church setting, when you're saying you can resume maximum capacity when you're vaccinated, but whose jurisdiction is it to confirm that verification of vaccination status. So again, an issue with the implementation, and I'm hoping that maybe after this year, we will provide feedback to MOH in terms of some of those directives. And because many of you here on the audience are healthcare workers, so we need to see, because even the few cases that are likely to come, we will be at the forefront of facing the brunt, and therefore we need to see how we can collectively protect ourselves. And then in terms of threshold for announcing the end of pandemic, I've actually never seen or reviewed that, and I don't know how we go about it, but it most likely, for example, in other outbreaks like Ebola or yellow fever, there has to be a certain percentage of number of cases, particularly for Ebola. You have to have a period where you've not reported a new case for a period of, I think it's 42, either 21 days or 42 days. So there has to be a certain period where no cases reported, but I don't know whether for COVID-19, what would really be the threshold numbers for announcing, considering that what we've seen with the pandemic, it keeps on like escalating between different continents. So moving between the Northern Hemisphere, the Southern Hemisphere, from South Africa to different, like Brazil and different countries. So I would have to check that up about what would be the global threshold to announce that the pandemic is behind us. And then in terms of the booster dose and the interval for booster dose, it would actually depend on what vaccine you received. So remember, your mRNA vaccines are given 2 doses, 28 days apart, and the booster dose is recommended thereafter. I think it's a period of, if you've received your mRNA vaccine 6 months prior, you can now go for your booster dose. And the interval again for, if you received your primary series of AstraZeneca, again, it's an interval of about 6 months to go for your booster dose, because that's the time the antibody response declines up to 8 months after the primary. Your second dose is your end of your primary series. So within an interval of about 6 months prior, then you can go to receive your booster dose. J&J is normally given as 1 dose vaccine, but the booster dose has now been recommended with an interval of 6 months between the first dose of J&J and a booster dose of J&J. So I think those were the questions that were asked, and I think there are other questions. Maybe you can read them for me so that I keep a tab of them.
Yes, there's Beldina has asked, is there a recommended threshold of the positivity rates that will trigger the reinstitution of measures? Then lastly, on the Q&A chat box, most of the clinicians were treating COVID-19 with azithromycin for 6 days. What's your feedback? Since this is a viral disease, how can we elaborate on this? You can look at those 2 first.
Yeah, so in terms of the trigger rate for positivity rate for that will trigger the reinstitution of measures, it's not really set. The positivity rate that is there is the one for easing the restriction, and by WHO it's set at about 5%. So a reduction, any positivity rate less than 5%, you can ease your measures. But reinstituting the measures, we currently don't have a global guidance to say that then if it's more than 5%, we reinstitute, but we are guided basically by the increasing surge in cases and the pressure on hospitals and the other complications that arise from that, because most often when you have pressure in hospitals, then you have an increased mortality also, which can occur within hospital or even at the community, because many people then cannot be able to meet the care or access the care that they require. So we don't really have a current threshold in terms of if our positivity rate was to increase to 5.4, all the measures would come back. We'd have to relook at all the data and look at what is the capacity we have currently in the hospital, what's the oxygen level, what are the things? Because normally when we put the restrictions or when the restrictions are instituted, they really help to reduce transmission between and therefore prevent generation of new cases and ease the burden on the hospital. So we don't have like a magical number as it were for now. The second question around the use of azithromycin, I think we've spoken to that in a previous webinar, and there's no evidence for use of azithromycin in improving morbidity, improving survival, improving outcomes in patients who have COVID-19. Because like you clearly said, it's a viral infection, and azithromycin is a macrolide antibiotic, and therefore there's no role for using azithromycin unless you have community-acquired pneumonia. But in the setting where you just have COVID-19 pneumonia, there's no role for azithromycin use. Thank you.
Thank you, Dr. Maybe I'll just give you two last ones, which were in the general chat box. There's an issue with there's genomic surveillance data from KWT indicating 8 cases of Omicron BA2 by for 14th of Feb. What could you, are there any updates maybe 1 month later after that time? Is there any update on that? And lastly, there's someone who asked about there are strict measures have been put on COVID-19 in churches, but there are no measures at the political gatherings. Is there any science around why the strict measures in churches are not political gatherings? So those are the last two questions that have picked.
Okay, thank you so much, Dr. Okinyi, for the two questions. So thank you, Dr. Mwiti, for the data, for sharing the data on surveillance data from Kemri Wellcome Trust, which I believe is Kilifi, around the 8 cases of BA2 as of February 14th. So I have not had a chance to review their data, either in a policy brief or something related to that. But basically, when you have cases, and that's the importance of genomic surveillance, because then you track the cases and you collect more data around where those samples were collected from, what is the likely impact. And then looking at February 14th up to where we are now, around March 23rd. And then even at the time when the directives were announced on March 11th, we have not demonstrated a surge in cases. So it's good to note that the BA2 variant is around in Kenya, has been picked by genomic surveillance, but more additional data would be important around those people and where they've visited, because then maybe the impact of that variant, maybe there are other factors that contribute to a surge in cases where that variant is introduced. And particularly, I think there's an influence of weather, because when you look at the periods when we've had a surge in cases, they've actually been characterized when you have our cold weather. And therefore, I think this hot sunshine we are experiencing now around March is sort of protecting us. But we need to keep our eyes open and just know that if the cases start to go up, the variants maybe would explain some of these cases. So it's just to continue the ongoing surveillance, because we should have seen something 1 month later, but we are not seeing a trend or an increase in the number of cases. And most facilities would have maybe 1 or 2 patients who maybe were being admitted for something else. And then when they were tested, they were found to have COVID-19. So we are keeping our eyes open and being alert, particularly because of what you've shared with us. And then Stephen's point is very pertinent, because we seem to have double standards where we are very strict in the church as opposed to political gatherings. But the caveat to that is that most political rallies would happen in an open space, an outdoor space, and people are likely to be outdoor. We are not, the risk is still there, particularly if you're one case, again, considering you're not socially distancing, but being outdoor is sort of protective compared to indoor. And that's why the face masks were being encouraged in an indoor setting. So it may seem to be that we are being stringent on the church and being lenient on the political gatherings, like we are turning our face to the other side to allow political rallies to continue. But maybe that's not really the case, but the risk is reduced in an outdoor space compared to an indoor space. And therefore, the additive benefits for the indoor space is really the masking and even the vaccination of the congregants, so that you derive the benefits of the public health measures that would be beneficial. But I agree with you. It may sound that the measures were announced to facilitate political rallies, but maybe that's not what we should perceive it to, because if we have that perception, then we are likely to have our risk lower, and therefore we are likely to be cynical about the directives and therefore even not adhere to any of the directives. So let's not take it that the state is against the churches and supports political rallies, but we just look at the directives in a global manner, in a balanced sort of manner. But again, even for people who attend political rallies, it doesn't mean your risk is minimal. So it would be good to have even the attendees who are vaccinated. And I wish the political leaders would use their campaign rallies to motivate people to go for the vaccine, because most of the politicians are actually vaccinated, but the people they are trying to get the votes from who come to the political rallies are not vaccinated. So it should be an opportunity to allow their potential voters to be vaccinated. Thank you.
Thank you very much, Daktari. It has been so insightful. Thank you for your time. I don't know, do you have any parting shot before we call it a day?
So I think my parting shot is really to encourage all of us to be vigilant. If we haven't gone for our boosters, let's go for our boosters. Let's be vigilant. Let's wear our face masks. Let's continue the hand hygiene. And if we notice a surge in cases, we are available through KMA or through other forums. We need to be able to report, because we are coming in this audience. We are many of us now today gathered. We are 393, and we come from all parts of this country. So if the cases are going to start going up, for example, maybe in Mandera and Wajir, let's be able to be the ones to pick these cases so that you can avert an outbreak, because we are not totally out of the woods. The risk is still there. So thank you very much for being a good audience, very participatory. And thank you, KMA, for this opportunity.
Thank you very much, Daktari. Thank you very much, members. That has been made simple. She has interpreted, and she has told us how we should implement and told us about the impact. This has been insightful. Thank you, Mwalimu. Actually, you've made it simple, and I think we could have not appreciated better. So at this moment, I'll request, I'm seeing the Vice President is still with us, to give us a 1 minute parting shot as we call it a day. Daktari, Dr. Sotara.
Okay. Thank you so much, Dr. Okinyi. And most importantly, I want to thank Marybeth for eloquently putting this across to us. Mwalimu, I did not sleep at all, at even 1 minute through your discussion, through your talk, so it tells you it was very stimulating. And I think the message is very clear to all of us as healthcare workers, and we can also propagate the message to the public. Let people know that we are not out of the woods yet. There are benefits that we have shared that are there in terms of the measures that were instituted. I think we need to continue encouraging people to go in this direction. And otherwise, also be on the lookout. Let us pick them early if at all there is a case that is coming up. With all those, I really want to appreciate you and appreciate our partners who have made this possible. And of course, Dr. Okinyi for ably taking us through this. Thank you all, and welcome again to the same talk next week, Thursday, same time. We continue the case management series. And of course, we usually have a webinar on Tuesday evening at 7 p.m. And that's usually the mentor series. With that, have a good day. Thank you, everybody.
Thank you, everybody. Thank you, Daktari. And for the person who has asked about pharmacists, how they get their CPD points, I know Peter will work on it and link them with the pharmacy and PSK to ensure that the pharmacists also get their CPD points. I hope, Peter, you will take note of that. Thank you, guys, and we wish you well. Have a great afternoon. Thank you.
Thank you. Bye-bye.
Okay, thanks. Bye.